Welcome to the second series of Fragility Fractures in Focus, hosted by me, Cesar Libanati, Senior Consultant, Medical Affairs at UCB. In this podcast, we welcome global experts in bone health to explore hot topics and innovations in osteoporosis, shining a light on the importance of secondary fracture prevention. As you will see in today's episodes, we also welcome and invite patients who suffer from the condition so they can share and provide their very important insights for all of us to hear. In every episode, we explore one of the P's of the P4 model, a framework increasingly recognized as the cornerstone of proactive modern medicines. Those four P's stand for predictive, preventive, personalized, and participatory. Today's episode is entitled Closing the Gap. It's make or break for post-fracture care, and we're kicking off with secondary fracture prevention. As many of you know, worldwide, 1 in 3 women over the age of 50 will experience a fracture caused by osteoporosis. What most of us do not appreciate, though, is that after experiencing a fracture, the risk for a subsequent fracture is 5 times higher in the year immediately after that fracture. And this will have profound impact on the quality of life for the patient and on the well-being of all those who care for that patient. It also has a significant implication for healthcare services. Today, as a follow-up to our first prevention episode, which we hosted with Dr. Maria Talla, when we heard about the incredible work her fracture liaison team is doing in Scotland, we will be exploring the barriers standing in the way of secondary fracture prevention and what we can do to overcome them. And for these, I'm delighted to be joined by 2 guests, Professor Qasim Javed, a professor of osteoporosis and adult rare bone diseases at the University of Oxford, and Mrs. Jennifer Fraser, who will provide important insights as a patient suffering from osteoporosis. So welcome you both, and if I may ask each one of you to briefly tell us a little bit about yourself. If we go first with you, Jennifer.
Well, I'm living in Scotland, and I was a radiographer when I was working, and my hobbies were hill walking in Scotland, and I have 2 children.
That is fantastic to start, and we'll get into more insights during the podcast. So thank you for that. Cass, go ahead.
I'm an adult rheumatologist, and my journey in bone started when I met someone called Professor Cyrus Cooper in Southampton, who inspired me to follow a career clinically and academically in osteoporosis. I finished my training in Southampton, did a PhD on developmental origins with Cyrus, and then with Cyrus we went to work with Michael Nevitt at UCSF, and then came back in Oxford, and then through Cyrus really opened the world of fracture liaison services, so systems where we can systematically close this care gap. And I work on that both locally in my hospital, regionally, nationally, and internationally now. And I also link that with research and work in rare bone diseases.
Wonderful, Cass, and I think all of our listeners know you, but in case you don't, Dr. Javed is an internationally recognized authority in the field, so we're really welcome to have him here today to go over the topic. So let's jump on the topic, and maybe I can start with you, Jennifer. Can I ask you to please share your journey with osteoporosis, including when you first were diagnosed and how it affected your daily life, and also told us a little bit about your first fracture, perhaps?
Yes, well, I was diagnosed 4 years ago, and that was moving a heavy piece of equipment in the house and felt, the sharp pain going down my leg, and I had electric shocks going across my sacroiliacs. And at the time, it was during part of COVID, so I went privately for an MRI scan. Actually, a straight X-ray would have shown it equally, but I chose the MRI, and the neurosurgeon said, I don't think it's osteoporosis. And I could see my fourth lumbar vertebrae was completely crushed. I don't know what he thought it was, but he didn't maybe want to let me down too quickly and was trying to prepare me for it. So anyway, we didn't, because it was private, you don't really follow on to the next stage like you do in the NHS. So I then had to go back to the GP and arrange a meeting with a rheumatologist. And that's how we took it from there with a bone scan, etc.
So how long did it take between your suffering that episode of sharp pain and getting to the point where you now have an idea of what really is going on and are ready to go back to your GP to take the next step?
Yeah, well, I was quite lucky. Even although it was COVID, I was seen quite quickly at rheumatology and then had, a diagnosis. And that was the hospital situation after that for my medication.
And did you feel along these interactions you had with different practitioners and physicians, did you feel that you had a good understanding of what was going on, that you were receiving sufficient information?
No, I don't think the GP, I really don't think the GP, if a 75-year-old woman presents with severe pain going down the leg and is a slim build, I would have thought that might have been, might have aroused in them an idea that it could be osteoporosis.
Wow. So actually it took probably that long before you eventually got to see so at least a month and a half or 2 months. And we'll talk, and probably Dr. Javedi will tell us why it is important to act very early on. Did anybody ask you or tell you about the disease osteoporosis, what you could do outside of taking eventually a medication? And did anybody tell you in particular that because you had a fracture, your risk of having another fracture in the immediate future, in the next 6 months to a year, was extremely increased?
I did a lot of research myself, and also had good advice from my daughter. I accessed the Royal Osteoporosis Society and printed off leaflets. And that's how I realised one could even exercise. Even although I'd been a radiographer, I didn't know you could exercise with a broken back. But obviously these exercises said, even although you have a fractured spine, you can exercise.
So you had to do a lot of your own research, and
yes.
You were a little bit blessed because your daughter had some knowledge of the condition and helped you direct, etc., which is not what every single patient has. Let's pivot to the practitioner. Cass, you've heard Jennifer's story and experience. In your own experience as a physician treating these patients, how common her story is in terms of presenting the clinical case, presenting with a fracture, and also her pathway to eventually getting into some appropriate care?
Thanks, Heath. Actually, it's quite common, and that's why we're so passionate about changing the trajectory. The knowledge around fractures, osteoporosis, and management is actually really well evidence-based, but it's almost in a bubble with only a few bone experts able to take that knowledge and bring it to their patients' benefit. And that's our real challenge, is to universalize it. And I do think that Jennifer's hit the button. I think a very key process is doing it through the patients. So the patients have really good information, and when they start searching for back pain or fractures, they get linked to the Royal Osteoporosis Society or other patient groups where there is good information. So it almost becomes impossible for a patient who searches on the web for osteoporosis not to have access to good quality information. And I think that will then help. I mean, primary care GPs are under tremendous pressure, and they have so many competing priorities. Of course, they have a duty of care for their patients and would want them all to be fully activated. But we now live in a healthcare system where actually you don't really always need to see a GP to be managed for your osteoporosis. The fracture liaison service model has clearly demonstrated that the nurses and other allied health professionals do probably a better job than we do in guiding their patients and supporting them through their osteoporosis diagnosis, early and late management.
So obviously, in both of your stories and insights and experience remind us of the significant gap that exists. And I would say it's gaps. I see that one of the gaps is the fact that we fail to recognize that a particular symptom, a severe episode of back pain with or without radiation in a patient who has risk factors for osteoporosis or is just age, is a possibility that a fracture has occurred. And we call this the silent fractures, correct? Which I think is also a misnomer, because when you talk to the patients, many times they tell you, yeah, I mean, 6 months ago or a year and a half ago, I remember very clearly having this sharp pain that I had to lay down for days, and they gave me some painkillers, etc. But nobody thought about osteoporosis. So there's that gap, which is a little bit of a gap in terms of the knowledge from the physicians. And then there's the gap of once the condition is recognized or the fracture is recognized, doing the right thing, and we'll talk about that later, and also informing the patient about what they should do or not do, and about the risk for having future fractures as well. Cass, you mentioned that time is a problem, correct? Because everybody's too busy, and people think that you need additional time to explain these things to the patient. But we had a previous podcast with Dr. Zoe Paskins, who basically gave us a number of clues on how practitioners could do that without adding time, and yet accomplish a very important task, which is informing and educating the patient. Tell me a little bit about, if you agree with these gaps, how do you, in your FLS system, take care of this aspect of interacting with the patient, having them be part of their disease and understanding it?
I think that's a really important question. I think the first thing is we have to make sure that the person that they're interacting with is adequately trained and knows their bone stuff. I mean, you have to be speaking with people who understand osteoporosis and can answer the common questions about what it is, why it's important, how do you diagnose and treat it. And I'm fully supportive of Zoe's amazing work, and she's doing a randomized controlled trial to see, to prove her hypothesis that this sort of patient-led approach, where you let the patient lead the discussion and you listen to their concerns and help that shape your conversation, is probably going to be very impactful in that it engages the patient going forward. We are developing very simple, what we call competencies, and that's through the Fragility Fracture Network, where actually, if you want to be seen as a FLS practitioner, you can go and check that you have the right skills. And we see that as a way for practitioners to become even better. And it also comes with experience. Jennifer probably saw someone who's seen hundreds of Jennifers, or even thousands. And with that experience, you do get confidence. And it's that trust and confidence in the person you're speaking to. It's so important to define how well people feel comfortable with the advice they've been given and how they follow it. And it really comes down to the fact that bone health is not a specialty. No one owns it. So it's sort of been left to a little bit of rheumatology, a little bit of endocrinology, a little bit of geriatrics, a little bit of orthopedics to do it. And this lack of a formal osteology or bone specialism has had this sort of ripple effect in that it's sort of unclear who owns that area of medicine, and through that, unclear of how you train people to deliver it very well.
No, I think you bring up very important points. And obviously these are significant challenges, but we need to find solutions. And I think and I'll, in a few minutes, I'll give you a thought that I have to basically get your thoughts on could this work as a simple potential solution. But before that, let me get back to Jennifer and ask you, what was your experience once this was diagnosed in terms of the positive aspects? There must have been some positive aspects, and also the challenges that you understood. Tell us a little bit.
Well, there were positive aspects. One, I told my cousin, I realized it must be in the DNA. And I told my cousin on the side of the family, I knew that the DNA was involved. And she turned out to have a worse T-score than I had. And yet she hadn't broken anything. She was 12 years younger. So she immediately went on a treatment. So I felt I'd helped someone in a family. So she's on medication, and being younger is probably helping to build new bone. Well, the good thing was that I was lucky to be put on a treatment quite quickly when I saw rheumatology, and I felt very confident. I actually didn't worry about breaking any more bones. I felt I'd had my share with 3 lumbar vertebrae, so I actually didn't. I just looked on the positive side and tried to keep exercising. And again, I know diet plays a part, but probably a small part.
So they explained to you also the importance of sufficient calcium intake. Cass, what other factors are preventing people with osteoporosis from getting the care they need post-fracture? Jennifer just told us that eventually she got to see the right physician and get on a therapy. But we know there's plenty of people that after a fracture do not receive any treatment. That's a big problem. So what do you think is causing that?
Well, it's a stepwise sequence of events. First of all, it's not recognized as a big priority for their locality, even though we know that hip fractures are, the number 2 or number 3 cause for people staying in hospital after emergency admission. But the problem is people see hip fracture when they should be seeing osteoporosis. And that's the first thing. Decision makers don't understand hip fracture is osteoporosis. And that's really challenged us when we hear about services to reduce osteoporosis impact. I think the system has to see that this is not a negotiable. This is basic care. We would not allow, and you've heard this refrain lots of times, Cesar, I mean, who would ever allow someone to have a heart attack to come into hospital and leave without putting them on a cholesterol, checking them for diabetes, checking their blood pressure? If you did that, you'd say that isn't a hospital. That's like crazy. You're just letting them be sick so they have another heart attack. And yet the system, and I'm not blaming professionals, this isn't about that at all, the system hasn't realized that the same applies to fractures. No one who's over 50 with a fracture should be able to leave a healthcare system without someone saying, what about your bone health? What about your falls risk? This is not something you do once you've finished all of your other priorities. This is your priority, because otherwise you're just going to let people fracture again. And, I think that's probably the biggest gap, because we know what to do. With Cesar's work and other people's work, we've got fantastic evidence for how to assess patients, how to find out who's at very high risk or moderate risk, how to tailor therapies to people, what to do after they finish treatment, what to do if they run into complications. We've even studied the rarest of all complications to the nth degree, just in case it happens. So we've got the evidence. It's just this gatekeeper block where we're being prevented from having the resources to just do our job and make sure that every fractured adult gets assessed for osteoporosis and Pfeiffer's.
Indeed, I mentioned earlier that I was going to provide a thought or an idea, and maybe it's being done in some areas, but I'd love to hear your thoughts on it. Obviously, people are busy. Obviously, in the setting of the immediate care of a fracture or a patient who's suffering an acute episode, you're thinking about too many other things. You have other priorities. But what about having a simple piece of paper with 4 bullet points? And one will say, you suffered a fracture, correct? And so you go to the ER, you fell, you fracture your wrist, and when you leave, the first bullet point will say, you had a fracture. This means that you will need treatment for the condition that caused your fracture, and that was not just the fall, correct? You had osteoporosis. Second bullet point, you must discuss with your physician to consider a treatment for that condition, because your risk of having another major fracture is significantly increased in the next year. And number 3, here is a link to the resources that you could study about regarding. So 3 simple, in big letters, bullet points. I don't hear that patients receive that when they go to an orthopedic clinic after they fell and had a fracture from the ER. Would you think that would provide the patients the power to go back to the physician and say, hey, I received this. Now, let's sit down here and talk about that. What do you think about it? Maybe you're already, Cass, implementing some of that in your setting.
Well, through the Fracture Liaison Service database at the Royal College of Physicians, we've actually developed the Stronger Bones After 50, which is what you've said, and also a video. And we've also got the 6 golden rules for people who've had a fracture. So we have those tools. What we find is generating pieces of paper in a busy hospital just doesn't cut it. There's so much information they're given, their appointment letter. And, osteoporosis is a difficult world. You realize the last 2 pieces of patient information I've given you do not mention the word osteoporosis. Stronger Bones After 50 and 6 golden rules after breaking a bone. And I think we have to use simple language. And I truly think it's going to be IT. You're going to have on your app, your NHS app, it will flag that you've had a broken bone. And the NHS app will say, okay, you need to, I can't see you've thought about your bone health. This is what you need to do. And that will then blend into AI chatbots, because it's quite a standard thing to have a conversation with someone about, you've broken your bone, how are you doing, how's the pain? And what we need to do, Cesar, I suggest, is actually blend it in. That is part of your recovery. If you've broken your wrist, or you've broken your hip, or you've broken your spine, you've had painkillers, you've had surgery, you haven't had surgery, it's blended in that we need to stop this from happening again. And that it can be delivered digitally. You can do it very nicely with animation. You can translate it where English isn't the first language. You can make it very simple for people whose reading age may not be as high as others. A great flexibility, and I think the tech will get there. That's the ultimate solution, because it's quite a standardized, approach. It's pretty straightforward. Break bone, weak bones equals management.
Thank you for that. Jennifer, you heard Kasim tell us what he's doing, and the tools are available, and how to reach the patient through basically technology. What are your thoughts?
I quite agree. I use the computer, and I looked up the Royal Osteoporosis Society, printed off their exercises, and also read that a form of exercise, Pilates, could be very good for this condition. And so that's another thing I'm doing. And yes, one has to help oneself, because we'd realize that the NHS is overstretched as it is. And the only thing I would say would be the annual bone scan might be helpful for a few years to see if the improvement's maintained after the medication.
Yeah, you brought actually, I'm going to pause here because you brought a couple of very important snippets of information, Jennifer. The first one was about the family history of osteoporosis. You said, well, I was diagnosed with this and immediately thought that perhaps my sister, my daughter, my cousin my cousin could have the disease, because indeed there is a genetic component that is very strong. So that's a message that I think is extremely important, not only for the physicians, which generally know that, but for the patients themselves, correct? That's fantastic. That's what you did. Cass, I know you have some comments to make about this because you see this every day in your clinic.
Yeah, I think that you've uncovered something quite important. The clinicians know how important family history is for that person, but I don't know of any clinicians who say, hang on, you've had a vertebral fracture, you've had a hip fracture, we need to screen your family. And we know from all of the data, parental history of hip fracture, double risk of fracture. It's a very strong risk factor, and we need to think of ways of and do the research where we can implement this within an NHS where, grandmother's got a hip fracture, what's happening to the daughter and what's happening to their child. And I think once we've hit secondary prevention, that will be the next study. We've had the SCOOP study. The two biggest risk factors for a sequencing program that predicted who did badly was, have you already broken a bone, which the FLS will scoop up, and did your parent break a hip? So, we can really simplify that message, and that would be transformative. It would really up the game, awareness, would suck in lifestyle, exercise, falls prevention, everything.
Absolutely. That really gets to the E of preventive. So I absolutely agree. The other important information you just mentioned, Jennifer, was the fact that this needs to be followed up. Osteoporosis is a chronic condition. And even after you receive good treatments, you just cannot say, all right, I'm done with this. We would have done with patients who have diabetes or hypertension. So thank you for that reminding. And I think it's very important for all of us and all in our audience to realize that and keep mentioning the importance of this follow-up with bone scans or with whatever other exams are needed to be done in order to know that you're improving, because there are many ways of improving the condition. So that's fantastic. All right. I would like to move a little bit to the fact that we know that this fracture episode, which could be so significant to the patient, also affords a unique opportunity to do what I would call the right thing, correct? Which is ensure that the patient is receiving the best possible care so that another fracture, which is very likely to occur in the immediate future, does not happen. That is entirely, could be entirely prevented. So for that, obviously, the patient needs to get involved. And Jen, how important is it for the patients to be actively involved in their post-fracture care and secondary fracture prevention? And we've heard also that you could get help from technology, etc. But in that regard, I would like to ask you also, how do we ensure that this signal, this message from the technology reaches you? Because I'm sure, like all of us, you're overwhelmed by the amount of messages, emails that you get on your phone or your computer. How can we prioritize this at the time that the patient needs it so they can indeed get the most advantage from the information?
I think it's very important to look up, as I say, the Osteoporosis Society's website for information, because as Cassim was saying, the GP doesn't have a lot of time to help. And the visit to the hospital to rheumatology once a year is a good option as well.
Thank you for that. Are there any particular, I'm asking you to think now for a second, are there any particular messages that you get on your computer or your phone that you immediately open, whereas others you ignore? And if that is the case, what is it that makes you bring you that urge to opening that particular message? I'm trying to find out here ways of reaching patients in a way that is more effective.
Well, I don't tend to look at other things apart from the official website. I don't use my phone for, just a chat conversation. There's some of these programs where you can speak to other people who've had the same experience. Because I think everybody is so individual, and sometimes I could find it quite depressing listening to other people's experience. They're maybe not so proactive, or, it's just a very individual thing, I think.
Okay, let's go back then to, thank you for that. Let's go back to the question of how important it is for the patient to be actively involved in their post-fracture care. And also, if you had an experience with individuals who are not responding the way you think is logical to that. For example, it could be a neighbor, it could be a friend at church where you talked about your experience, and despite your mentioning, they don't react in a way that you would say makes them interested and involved in their self-care.
It's a difficult one, because mainly my friends are physios, radiographers, doctors, people like that. I probably don't meet so many other people now.
Okay, good enough. That's good to know. Tell us, how can healthcare professionals ensure that patients receive the right information to make the informed decisions about their treatment? And also, you may want to comment on the question I asked Jennifer a few seconds ago.
Yeah, I think this is actually an information and marketing issue for Jennifer's question. I do see very informed people who have accessed online resources that have frankly terrified them about osteoporosis management. It could be through their dentist, it could be through colleagues, it could be through peers, or what they've just heard on the web. And I think we just have to call it out for what it is, that actually, calcium, vitamin D, dietary supplements are not enough. The treatments are safe, they reduce fractures, and they don't cause, in the whole, problems that many people are worried about. And I think the one thing that we always struggle with as clinicians who will say, I'm starting you on drug A and its side effects are ABC. We should say, I'm starting your drug A and it will improve your bone density and reduce your risk of fractures. And that by not starting treatment is a huge decision. To say I'm going to be unprotected from progressive bone loss because I am fearful of rare side effects is a perfectly acceptable decision for a patient, but they shouldn't underestimate that is a huge lifestyle choice they're making, because that's a very, very risky decision, way more riskier than accepting the treatment and the risk of a rare side effect. And that disconnect between not accepting treatment is a big decision, is often missed.
Yes, I couldn't agree more. I personally didn't read the side effects because if my rheumatologist says this is the best treatment we can offer you, and he's the expert, he's got all the statistics, why would I even start to disagree? Well, why do we have experts if patients feel that they know better?
I think you all bring important points, and at the end, obviously, experience is very, very important. But I think it's also very important to respect the patient's decision. Correct. At the end of the day, we heard from many experts that unless the patient is convinced that this is something they need and it's good for them, they may start a treatment, but then they will stop it. So all of this, and at the end of the day, information is important, and that has to be personalized because it depends on the education of the patient, their life situation, their level of support. And on talking about level of support, I'd like to ask the two of you, how do you see the system, the medical system interacting as one? And I'll start with you, Jennifer, and then I'll let Cass comment on what he's doing to improve on the realities. And the question for you, Jennifer, is, in your case, did you feel that the rheumatologist and then your general practitioner and then the nurse that took care of you at some time were all in tune? They were all in agreement, and they were all knowledgeable about what was best for you?
No, I would say rheumatology was the best. Because it was partly lockdown, the phone call to the nurse said she would get back in 3 to 5 days and didn't. So that wasn't very helpful. And the GP had to Google the medication because they'd never heard of it. So all in all, rheumatology wins.
Thank you for that. And this brings the important point of this needs to change and this needs to improve. I think it's your experience was very common, and it leaves you a little bit on the not knowing what to do and the uncertainty. Cass, I know you're working strongly on the connection with the GP and making sure your team is all aligned, understands the need for the patient. How have you accomplished that, and what else needs to be done to improve that at the system level or at the personal level? Because I think if we always blame the system, nothing will happen soon enough. We all need to take some responsibility, and you've done that. So tell us the story behind your success.
Yeah, so the story was really with Professor Muir Gray. He's a very famous and very influential clinician in the UK, and I just bumped into him through another meeting, through a student of mine, Anand Jani. And basically, he looked at me very critically. He's got this look in his eye and he said, Kasim, what are you responsible for? The person who comes through your door in your fancy clinic, in your fancy hospital, or all the patients in Oxfordshire? And I said, well, I'm responsible for all the patients in Oxfordshire because I know most of the bone health. So then we, from that, built a system that actually the fracture liaison service is responsible for your bone health care for the first year. So if there is a question that anyone has in the FLS, they contact the FLS, and the FLS will deal with it. Very close working with primary care, our primary care pharmacists, practice nurses and GPs, really important for that, prescribing once they in the community. But in terms of technical questions, we'll do that. And we actually said something quite unusual to patients, and it doesn't really happen otherwise. It's so important that you get on with the treatment recommendations we start with. We are going to call you at 16 and 52 weeks just to make sure you're getting on. We are going to actively support you to stay on treatment. Whereas for any other disease, usually, you give the recommendation, and if there's a problem, we rely on the patient coming back to the healthcare system. We said, that doesn't really work for osteoporosis. We're going to flip the tables. It's too important for us not to support you enough to stay on treatment. And that is why this golden year of getting people on the right treatment, so they, we may get the first recommendation wrong. They may not get on with the first treatment. We'll switch them. We'll personalize their treatment. And I think that is a solution. And it doesn't have to be delivered by doctors in clinics. This can be delivered by competency-based approach, where anyone who's suitably trained can deliver this. It could be a pharmacist, a practice nurse, to be a radiographer. It could be an FLS nurse. I think that's how you do it. You see the problem, and then without conforming to structure, just think, well, what is the best solution for this? Forget about the history. Going forward for 20 years, what does good look like? And that's what you shoot for.
Thank you. Jennifer, may I ask you to think about a couple of pieces of advice that you'd like to give to all the physicians that are listening today regarding what they should do so that people like you get the best experience within the medical care?
Well, first of all, I think although the GP is under pressure to give you maybe 10 minutes maximum, I think they should listen to the patient and perhaps take into consideration, as I've said already, the age of the patient, the build of the patient, just certain pointers. I mean, for somebody who's always walked normally, to go in sort of like a half-shut knife to the GP and he says, "Can't you stand up straight?" he said to me. And I said, "Well, no, I can't." And, that was a pointer that there was something quite wrong. And that's where I feel they should maybe just take it a bit further.
Thank you, Jennifer. I didn't disclose this, but I'm a geriatrician, and a great mentor of mine once told me, "Cesar, as you go into the life of helping patients, remember this: you will help more people through your ears than through any other tool that you have at your disposition." So listening to the patient is so key, and I urge all of us to remember that. So we're getting to the end of this wonderful podcast. I certainly want to thank the two of you. But as a summary, I think we've learned about these gaps that exist, and they exist in part because we all feel that we're too busy to do the right thing. And that should never be an excuse. Jennifer and Dr. Javed provide us a number of insights that we've heard today. And I would like to say that this is a call to action to us. And I like to, in that regard, remind everybody that we need to keep informed about this. And there's a great opportunity coming up. The World Congress of Osteoporosis will be hosted in London in April. And there will be a number of sessions that are important. In particular, I'd like to mention, since he's here, the session that Dr. Javed will have meet the experts on the topic. So great opportunity to keep being informed and learn. And with that, I really want to thank our guest, Professor Kassim Javed and Mrs. Jennifer Fraser, for your time, for all your insights, and for all your recommendations. And I want to thank all of our listeners. And with that, I would like to say, go and have a great day, but also give the both of you an opportunity to just give some departing words. Jennifer first, and then Cass.
Well, thank you. It's been very informative, and I will tell my friends and let them hear the recording and maybe help some other people in the future approaching my age. As you say, it's 1 in 3. So I've got a big circle of friends, so I will tell them all. And thank you for having me.
2 things. I'd like to thank Cesar for this podcast and his incredible contributions to the field. It's not well known enough, but Cesar's been tremendous for the field. But I'd also like to say, if this podcast has inspired you to think differently about how you deliver care for your region, then get in touch. This is a golden moment. Close the care gap and make sure no one's left behind after a fracture, after a fall.
Thank you. Thank you both again. And now let's all go and do the right thing.